Sarah Bär, it's a great pleasure to welcome you on this interview. I would like to welcome you here, and the reason for our interview is a paper that was recently published by you and the team, and that is entitled Quantitative Flow Ratio to Predict Non-Target Vessel-Related Events at 5 years in patients with STEMI undergoing PCI, and it was recently published in the Journal of the American Heart Association. And it's quite a significant study with very interesting results. Well, you will explain that also. But before we continue with some questions, can you introduce yourself? You are working at the University Hospital in Bern, but what do you do during the normal week? And particularly, of course, your input and say results that you are presenting here in this particular paper.
Yes, so thank you so much for the opportunity to talk about our study. My name is Sarah Bär. I am a Cardiology Fellow at Bern University Hospital in Switzerland, and since approximately 1.5 years, I am engaged in research in the team of Professor Reiber. And since 2019, I am involved in QFR analysis and paper writing, and my experience is maybe around that I have analyzed myself around 2,000 vessels or a bit more. And the Comfortable QFR is the first QFR publication from our research group, but we are working on more, and we hope to provide more QFR publications in the close future.
Yeah, so you're really an expert user with more than 2,000 cases. It's enormous.
Yeah, I don't know if expert, but at least I spent many hours on QFR, yes.
Yeah, I can see that. And also, of course, in this publication, there were already so many cases that you have analyzed, and you're doing additional research. So the numbers add up, and the number of hours that you have spent on it also are, with all these numbers, quite significant. As I mentioned, also this was recently published in the Journal of the American Heart Association. And can you summarize, say, the work presented in this paper?
Yes, so in the Comfortable QFR study that was recently published in the Journal of the American Heart Association, we performed QFR in 946 non-target vessels in 617 STEMI patients from the Comfortable AMI trial. The Comfortable AMI trial was a large international RCT to compare bare method to drug-eluting stents in STEMI patients. And the patients of this trial underwent angiography-guided complete revascularization, which means that all non-carpet lesions of at least 70% diameter stenosis, or those with 50% stenosis according to the operator's discretion, were treated. So this was a fully revascularized STEMI population based on an angiographic assessment. And the question of the current QFR study in this population was whether QFR has incremental value over angiography-guided non-carpet lesion assessment in these STEMI patients. And to answer these questions, we aim to perform QFR in all non-target vessels that were left untreated. They had to have a proximal reference diameter of at least 2 millimeters, but otherwise there were no exclusion criteria. So we did not choose any angiographic stenosis pre-selection. It was really an assessment of all vessels that were technically analyzable. The QFR was performed by operators blinded for the clinical outcomes, and the primary endpoint was actually the composite of cardiac death, spontaneous non-target vessel MI, and non-target vessel revascularization through 5 years of follow-up. And then the results, the primary endpoint occurred in 62.9% in the QFR 0.8 or below group, compared to 12.5% in the QFR above 0.8 group. This resulted in a hazard ratio of around 7 and a highly significant p-value of below 0.001. This result was driven by significant differences with respect to non-target vessel MI and non-TVR, with no significant differences in cardiac death alone. We have also added an independent predictor analysis, where interestingly QFR emerged as an independent predictor of the primary endpoint at 5 years, which was interestingly not the case for the anatomical parameter diameter stenosis 50% according to 3D QCA. So in summary, the results of this study suggest incremental diagnostic and also prognostic value over angiography in non-complete lesion assessment of STEMI patients.
Yeah. And that is indeed a major achievement. And I think what you also wrote, that the strength of your study it's a randomized, controlled, multi-center design. And if you look at also at the paper, there are many, say, high-ranking sites involved in the study. It's independent event adjudication, QFR blinded indeed for patient outcome, a follow-up of 5 years. So that is also very significant. And a sample size of 617 patients and 946 vessels. And that is indeed, as you mentioned already, the largest data set published on QFR in patients with STEMI. Right? And anything to add to that point? I think it's a major, and also a follow-up of 5 years is really significant.
Yes, so I think we are lucky to have such a high quality data set and to use this data for further analysis. So I think the quality is very good, and it was a great opportunity to test the value of QFR in such a population. And of course, one disadvantage of a long-term follow-up is that event risk may change. This is one of the limitations, but we have addressed this in the paper by performing ROC analysis per year and with very consistent results. But otherwise, yes, it's very nice to have such a great data set and perform the QFR in this setting. Yes.
Yeah, and as it also very clearly mentioned, but then maybe we are repeating ourselves under clinical implications, and that you mentioned that the QFR shows really incremented value over angiography alone in the non-complete lesion assessment in patients with STEMI. And that is, of course, a very important finding, and that it's also a convenient and non-invasive vasodilator-free method to assess the lesion significance, the physiologic lesion significance. You mentioned also in the paper that the best QFR cutoff to predict the primary endpoint was 0.93. So what does that mean now in practice? And also, do you use now your algorithm that you have developed here in clinical practice, or is that still too early?
Yes, so maybe first of all about this optimal cutoff point, which was indeed 0.93 to detect 5-year MACE. This is, of course, way above the ischemic threshold of 0.8, and it's interesting but very consistent with previous research on FFR and other physiologic indexes. The evidence of all of these studies who assessed the optimal cutoff point seems to go into a direction of a bit the higher the better. So this is also a concept that is confirmed by the numerous studies that assessed post-PCI functional values. Yeah. And showing lower subsequent event rates with higher post-PCI values. So there seems to be something more that may need to be achieved except crossing the ischemic threshold. And this is very consistent, and of course should trigger further research to really find out what are treatment goals. Yes.
Yeah. As you mentioned also, there are multiple studies that where the post-PCI QFR should be in the range of ranges from 0.98 to 0.91. You find here with the 5-year follow-up 0.93. But it's clear that if you want to achieve a result that is event-free over multiple years, then you need to be in that range of 0.90, 0.93. I mean, that is very clear as an approach that need to be achieved, or a result that need to be achieved in the cath lab.
Yes, exactly.
But do you use is it also used in the cath lab now by the interventional cardiologists? They say when they do a PCI, it should be above 0.90, 0.93, whatever in that range. Is that used in the daily practice?
So in our center, it's not yet used. And I think generally we have to be a bit cautious because data are probably yet too limited to allow for a routine implementation of the QFR in non-carpet lesion assessment and especially treatment of STEMI patients. So first of all, it is currently unknown what really drives the events in STEMI patients with multivessel disease. So is it the stenosis severity, is it the functional significance, or is it rather the plaque characteristics? This is an issue that, or is it a combination of all? So this question is not totally clear, and maybe as a first step, the value of a physiology-guided non-carpet lesion PCI in STEMI needs to be established with RCT data, because currently we do only have data from the compare acute and dynamic pre-multi RCTs, showing superiority of the FFR-guided complete revasc compared to carpet lesion-only PCI in STEMI, but the direct randomized controlled comparisons of FFR versus angio-guided PCI in the STEMI population is lacking to date. And there is studies ongoing. So one RCT, the Flower MI trial, is investigating the issue. But first of all, the role of the physiology really has to be established in the STEMI population. And of course, if there is firm data, the time for a large QFR RCT has come also for STEMI patients, and this may guide further management, yes, of course. And also, maybe we need to wait for the two RCTs, the favored three RCTs, China and Europe, Japan, which are RCTs to compare QFR versus either angio or FFR-guided PCI in stable patients or stabilized HCS patients. And before these results, it is very really too early to routinely implement it. For specific questions, we have already used it. So, for example, patients with significant renal insufficiency, where we really want to avoid more contrast on very unstable patients, we sometimes did a QFR, but not in routine so far. Yes.
Okay. You mentioned already also that you're also working on other projects. You have done these 2,000 cases roughly. Can you say a little bit about what other projects you're working on with the QFR?
Yes, so we are working on another retrospective analysis on 1,400 ACS patients, which were planned for a stage PCI after hospital discharge. And the question is whether QFR has any value in defining the optimal time point of non-carpet lesion PCI, because this is another unanswered question to date. Yes, and then we have one prospective QFR sub-study in the Pacman-AMI trial. The Pacman-AMI trial is a multi-center international RCT to compare the effect of PCSK9 inhibitors versus placebo on top of high-intensity statin therapy in ACS patients. It's an intravascular imaging trial, but the question we are addressing with the QFR sub-study is whether treatment with PCSK9 inhibitors has an effect on QFR at 1 year follow-up compared to placebo. And then we are also performing a prospective validation study of QFR against FFR in left main disease. This is the optical left main study. And this will be a very important study because, as in STEMI, where FFR is technically challenging, it is especially also the case for left main disease. And QFR, if it proves to be valid, could be a very convenient option in this population. But data is extremely limited, and so a validation study is needed. And especially also because Medina 111 lesions are currently in exclusion criteria for the QFR. This study aims also to assess all left main lesions, including also the Medina 111 lesions, and compare to FFR. And this will hopefully provide important insights on the value of QFR in this left main disease population. Yes. So
that's indeed a very important study, and we are working on that also together. And of course, it is indeed in those particular cases not always easy to determine, for example, normal values and so on, and to make to take into account that you have a major side branch, but also with future solutions of QFR that will also be easier to take care of. But in the meantime, you are working with the current solution, and what we have seen so far, very interesting results also. And so with all the work that you're doing and the team there, we are certainly looking forward to many more publications in the future from you.
Yeah, let's go.
And so I thank you very much, and I think we have come to almost a close of this interview. You must have had quite some reactions also on this American Heart publication, and because it's very interesting. So I wish you much success with all the work that you're doing, and maybe we can reconvene again on another publication that comes out soon from your team in Bern. So with that, I would like to thank you very much and look forward to next results.
Thank you so much.
Thank you.